Good morning, everybody. My name is Jean Fajadet, and we will, with Thomas, will share this symposium with a live case from Toulouse. We will focus today on the optimal management of high bleeding risk patient with multivessel disease. Here we are on the podium, very happy to have Chema, Valeria, Davide, and Rasha. Okay, the objective of the session are the following. First, to discuss about the optimal management of high bleeding risk patient with multivessel disease. And second, more practically, to analyze how intracoronary imaging first and physiology could optimize procedural outcome in this type of patients. Next, I think we will get all the session team today. So Rasha will be our procedural analyst. Our discussion, I tell you, Davide, José, and Valeria. In Toulouse, in the cath lab, the two operators will be Benjamin Ronton and Bruno Farah. Our cath lab medical coordinator is Clémence, and on-stage medical coordinator, Julia. Next. So important, because every year we have a lot of questions or comments. So you have two possibilities to ask question or to give you comment. First, using the mobile application, or second, you can use in the alleys the standing microphone. So, tomorrow we present you the clinical history of this patient, and then we could discuss, before taking the line to Toulouse, about the particularity of the clinical and angiography particularity of this patient.
Yeah, thank you, Jean. Dear colleague, indeed, we'll share with you the case selected by the team in Toulouse. And before going live, we'll have time to discuss the case about the strategy. So really, please send us your comment, question, and contribution either by the microphone in the room or in the app. So as you can see, it's a regular elderly and high bleeding risk patient. It's a male of 85 years old, coming with a stable angina. And on the non-invasive testing, namely myocardial scintigraphy, this patient had significant ischemia in the emphero-apical part with some degree of ejection fraction decline after the stress. And accordingly, because of symptom and ischemia, this patient was scheduled for invasive coronary angiography. Has significant prior medical history. The patient had a pacemaker, paroxysmal atrial fibrillation, and 15 years ago, he has been already treated by a drug-eluting stent on the LAD. If you have the patient details, just showing mainly that we are dealing with a very active patient still and significant cardiovascular risk factors with diabetes, hypertension, and dyslipidemia. As the medical therapy, this patient received a low-dose apixaban for atrial fibrillation associated with a single antiplatelet therapy with aspirin. And he has also some medication, both to tackle the risk factors that we've just described, but also some degree of anti-ischemic drugs and mainly low dose of beta blockers. On the laboratory investigation, patient had normal hemoglobin, no significant troponin release, but as you can see, a slight degree of renal dysfunction in these 85 years old patients. So now let's move to the coronary, invasive coronary angiography, and you can already see, even before the contrast, that there is a diffuse disease with some degree of calcification, and we can see already a significant lesion on the LAD that we will see much better on the cranial view. And interestingly, just remember that the patient had already PCI of the LAD. It will be interesting to discuss whether we have a de novo lesion, an instant restenosis, or probably the two types of lesion. Again, on this view, we can see that there is also intermediate and significantly calcified lesion on the left main that will need to be discussed and probably assessed. And on this view, we can see a bifurcation lesion on the circ with the first marginal branch on quite small vessel, but still probably a 111 lesion. And again, on the right, there is in the mid part of the right coronary artery what we can call at least significant, if not critical lesion of the mid RCA that we can see nicely also on this view. So just to summarize the patient presentation and the risk assessment as well. So we are dealing with elderly patient, 85 years old, 3-vessel disease, mildly reduced ejection fraction in diabetic patients. And according to this, let's say, global presentation of the patient, the decision of the team was to go for percutaneous revascularization with a stage PCI. And accordingly, the team in Toulouse decided to treat first, probably the most critical, but also not the most complex lesion, which was the tight lesion in the mid-right coronary artery. And they implanted Ultimaster Nagomi 275 by 8 millimeters. And as you can see on the right part of the slide with the good angiographic results. So just to summarize and to open the case for discussion, we have elderly patient with oral anticoagulation coming for both angina and identified ischemia on the non-invasive test. 3-vessel disease with already recent PCI of the right and still significant and calcified lesion on the LAD and the circ with what we can call on the angio, Jean, intermediate lesion in the left main. And I think Jean's case can be now open for discussion with the panel and of course with the audience.
No, it's true that the difficulty here in this patient, which was octogenarian, diabetic, normal renal function, and this problem of hybriding risk, the problem for me is the left main. But there is no doubt on the 3-vessel disease. Mid-right was critical and already treated. LAD is really severe. And we have this lesion at the bifurcation CXOM. But when you look at the angiography, before the injection of contrast media from the guiding catheter, we have really a zone taking all the length of the left main and the distality of the left main, which is calcified. Right. And so the difficulty with it to appreciate exactly the amount of calcium on this left main, and if we need or not to revascularize this left main.
Yes, maybe Jean, we are dealing with elderly, challenging patient, multivessel disease, and the first question for you, Valeria, we learned for many years the concept of complete revascularization for the best prognosis of the patient. What is your practice in such frail elderly patient with high bleeding risk?
Thanks, Thomas. That's a great point. Indeed, complete revascularization. But we're facing now a stable patient. So we're not talking about an acute coronary syndrome, first of all. And then when we look at this patient with a really high bleeding risk and also high ischemic risk from an anatomical point of view, left main bifurcation, procedural point of view, multivessel disease, and also patient-related CKD and diabetes. I mean, this patient is really complex. So I would aim for relief of symptoms and reduce the ischemic burden.
Okay, so it's not complete revasc is not absolute rule in this kind of frail patient.
We can ask to Davide, when you look at the clinical presentation of the patient, this is octogenarian symptomatic, and here are evidence of ischemia in infero-apical wall, and with a light the LV dysfunction. So when we have this kind of, ischemia already shown by the non-invasive test, is there a place for intracoronary physiology testing?
Okay, so let's say, of course, a three-vessel disease, left main, I think particularly in high bleeding risk patient, we need to simplify the procedure as much as possible to avoid placing too many stents. Otherwise, we become reliant on the APT for a longer period, and this may be an issue with this patient. So using IFR or FFR in this case can help us to rule out some lesions that look like tight and they are not functionally significant. I'm thinking of the circumflex in particular, because the scintigraphy tells us that the anterior wall and the inferior wall are involved, so the LAD left main system and the right coronary artery. We don't know about the circumflex, but because this is already a very complex patient, I would recommend not to study this circumflex because the scintigraphy was negative on the lateral wall. So this is a situation where I would try to avoid looking for troubles, because we have already many troubles to address.
Yeah. Okay, thank you, Davide.
Maybe, Chiama, speaking about the left main, it's nice that the comment from Davide is aligned with what Valeria said already about the complete revasc. This left main and the angio, it's what we call intermediate. And in our words, I mean, intermediate means I don't really know. That's what it means. How you will assess the left main then to decide in this specific anatomy?
Yes, Thomas. I think left main is going to be a bystander here, because the capillary lesions are clearly LAD, which is pretty severe, and maybe CERC, I don't know. The right was also treated. There was ischemia in the scintigraphy. For assessment of the left main, you see angiographically an ambiguous lesion. We have physiology, but physiology, we have the problem with the downstream lesions. You have lesions in LAD and CERC, then you cannot make the evaluation properly. Imaging, I think, is better because you have the possibility not only of assessing the lumen, but also the calcification, the plaque distribution, the compromise of the ostium of CERC and LAD in order to plan the treatment of the left main if you are going to treat it. And we have cutoff. What cutoff? We use a cutoff that comes from all the studies we conducted, which is to use 6 square millimeters with IVUS. If you have the federal criteria, you have more than 6, you can leave alone. If you have less than 6, you should treat. Definitely, it is less than 4.5 or 5 is significant. Between 5 and 6 square millimeters is the gray zone that sometimes we do physiology. But keep in mind that for doing physiology here, you need to treat first LAD and CERC in order to have the flow. Then, in my view, imaging is better for this left main. You have the advantage of not having the problem of the blood and contaminating the lumen of the left main, and the contrast is a kidney disease. And also we had the cutoff. OCT could be used as well. The cutoff is not so clear, it's not validated. It should be around 5.5, not 6 for OCT. But definitely I would use imaging on this complex of the left main to see the lumen with these cutoffs in mind, and also the distribution of the plaque and calcification.
Okay, so physiology difficult because of the other lesions, so yes. Probably imaging, and 6 cutoff for IVUS and 5.5 if 5.5 CT.
Yeah. So I have another question. When you look at the angiography, it's a really calcified left main and proximal LAD lesion. So Valeria, when you see this angiography feature, do you see that there is a room for plaque preparation, plaque modification? And when you see this angiography, do you decide to use a plaque modification device just on the angiography, or do we need intracoronary imaging?
A great question indeed. From angiography, you see that it looks like a very severe calcium in the left main. But we need to see more and understand the calcium distribution. If this calcium is only in the vessel wall, or is a superficial calcium also affecting the lumen? So we need to understand that better. I think intravascular image can really guide us. And at that point, I would choose for one device or the other, depending on the presence, for example, of calcific nodule. You might expect the ostiumal LAD or bifurcation presence of calcified nodule. We want to understand better what's going on in that stent, in the proximal LAD, for eventually consider IVL treatment. But long lesion and discrepancy between calibers in the left main and LAD may also open, for example, the way for orbital atherectomy.
And Valeria, speaking about dedicated device for calcium, the fact that this patient had a stent 15 years ago, do you see it as an issue or not to use, for example, the different type of atherectomy?
Yeah, that's also a very good point. I mean, we don't have data about the use of orbital when you treat a lesion, a stent implanted 15 years ago. We have more reassuring data for what concerns the treatment of IVL, but indeed, the stent was placed 15 years ago. I think it's more important now to understand what's the mechanism of this stent failure.
So stent many years ago, not big issue for dedicated device. Yeah, probably we can now have more in-depth analysis, Jean, of the angio, thanks to Rasha. Please, Rasha.
Thank you, Thomas. So we just have to keep in mind that the images that we have are limited because of contrast, and the patient has CKD, but we can gain a lot from what we have so far. So this is the cranial view, and you can appreciate, obviously, it's very clear, the LAD lesion right here. So I don't think anybody can argue with that. The question is, where exactly within the stent is this? So the stent technically ends around here, at least based on angiography. So there is a possibility that this lesion is beyond the stent. Now, moving on to another important aspect is we don't really know the extent of the bifurcation up into the diagonal right here. So another cranial view would open up, and there seems to be also another diagonal lesion there. And one more important thing that we talked about already this morning, earlier today, is that you also have this short left main, and you get the sense that there is actually tubular disease. So if you look at the caliber of the left main here, it's actually similar to the caliber of the LAD. So it gives you a sense there might be actually more significant disease here than we think. Right before the injection, and it's really important to pay attention and do a cine with a few seconds before contrast, and you can clearly see the amount of calcium here extending from the left main all the way down to the LAD. So what we don't know yet, and I think imaging will definitely help a role here, is that one is we need to know how much, what's the minimal luminal area in the left main and if we need to treat or not. Two is we want to see the extent of the ISR, and the mechanism of ISR and the extent of disease beyond the stent or not. And the third thing is that also to look at the calcium distribution and whether any calcium modification technique that we need to use, or if we need to use, and what kind to use as well. And then one last thing on this slide is that if the left main is significant, and if the operator needs to stent beyond the initial stent, it would be nice to have a platform that covers all the way from distal to proximal with a long stent. And most importantly, it has the capability of oversizing in the proximal segment. So we know that they did a 3.5 around here. So a 3.5 can expand to 6.25 in some platforms. Now, moving on to the second slide, which is on the caudal image. And before we move on to the circ, just one more point on the LAD lesion. If the left main is not significant, they do have a good landing zone, at least angiographically, which we'll see on imaging. They just need to make sure that it's proximal enough to the diagonal for a good pot. Now, moving on to the last lesion here, we do have a circ lesion. It's more of an OM2, but it's also bifurcating OMs. It is a 1-1-1, but we have to keep in mind the size is around 2.5. The ostium of the side branch is actually less than 5 millimeter in terms of length. So if the operator decides to treat, especially with the clinical scenario of high bleeding risk, a provisional strategy might work in this scenario. Thank you, Jean.
Thank you, Rasha.
Thank you, Rasha. So now Thomas, you can summarize the situation and look at the strategy. Before that, we have one question coming from the audience. Explain, and you will explain, the risk and the benefit of staging procedure.
To stage, yeah.
Before starting.
Yeah, it's always difficult discussion because we have elderly patients which sometimes have very challenging vascular access. So it's true that sometimes we want to do all in one if the vascular access is difficult. But on the other side, we have patients with impaired renal function in which we want to save some contrast also, and sometimes to split the procedure, especially when we know and we have the feeling that the second one will be more complex with left main, LAD, and maybe the circ as well. So I think there is pros and cons, as always, but probably if we don't have very challenging vascular access, I will also go for stage for safer reasons.
Second question, coming from the audience. It's patient octogenarian, I think it's 85 years old. When you look at a lesion of the left main, which is calcified, in one view, cranial view, it looks at angiographically 50%. In the apicaudal view, is less than 30%. In other words, in this intermediate lesion, the age of the patient is a major impact on the decision of the angioplasty. In other words, same lesion in a 50-year-old patient, we change the strategy or not, compared to 85.
Thank you, Jean. It's a very challenging question. I think
it's my role, to give you the question.
As we discussed, I think for the circ, clearly 85 or 45, it's another story, but still left main is the left main. So I think I will keep the same way assessing the left main as we discussed, either physiology, which might be challenging here because of the downstream lesion, so probably by imaging. And after, we just have to decide. I think in very frail elderly patients, sometimes you can decide medical treatment, but still, I think it's the left main, and we need to assess it properly, I think. So just before going to Toulouse and join Benjamin and Bruno for the management of this case, we would like to share with you what the team in Toulouse decided to propose to this patient. And accordingly, just to review the objective we'll try to achieve together with this live case, it's of course, as we already start to do, discuss management of complex multivessel disease, to illustrate the role of intracoronary imaging in complex PCI, and probably more to the end of the session to also review the possible DAPT strategies for such high-bleeding risk patients with complex multivessel disease. And the procedure decided in Toulouse, again, was to do a staged procedure because PCI of the right has been done in the first setting with the right transradial access using glide sheet slender and 7 French extra backup guiding, to use a high-quality OCT acquisition for many objectives. The first is to assess the lesion of the LAD, and as we discussed, the degree of calcification, but also to know more about the instant restenosis mechanism in the LAD, and of course, to assess the left main lesion, which is still ambiguous on the angiography. And based on that, they will do OCT-guided treatment of the LAD and maybe the left main, and they will take final decision for the circ strategy. So Jean, that's the plan of the team in Toulouse. So I think we can join Benjamin and Bruno in Toulouse in the cath lab.
Hello?
Hello.
I don't know. Hello, do you hear us? Yes?
Yes, yeah. Perfectly.
Hello, Thomas. Hello, Jean. Nice to see you. We have already heard all the comments of the experts, and we agree fully what has been done. We are already advanced in the case, and we have done the OCT, the intracoronary imaging, in order to clarify some point, the point of discussion to treat this patient as good as possible. And I think that now we are ready, and with Benjamin, we will comment the OCT record. So Benjamin, you have done the OCT. There is many points to discuss. The first point is the mechanism of the instant restenosis in the LAD. What's the point?
Absolutely. And first of all, I want to show you the OCT that we use because we use a new catheter, which is a VIS catheter, which has 1.8 French compatible, and you can see how it easily crosses the instant restenosis without predilatation. So this new catheter allows axial resolution of 12 micron and a depth of 16 millimeters. So it could be very useful to analyze the left main because you raised the issue of the left main, which was the main issue that we have to face with Bruno. Do we have to treat this left main? And if you go on the OCT, we dive directly on the pullback of the OCT. We will go first on morphology. And morphology at the level of the instant restenosis, you can appreciate that the MSA is at 0.8 millimeter square, so very tight, and we know it from the angio. However, we have information on the mechanism, and you can nicely appreciate that there is a lipid plaque. It's neoatherosclerosis with the lipid plaque. If we go a little bit higher, you will see that the osteomos diagonal is involved on the stent. It's covered by the procedural stent. You can see my guide wire at 5 o'clock, which go through the struts. And this is something that we have to take into account, because if we have to treat with a new stent, which will be probably the case with neoatherosclerosis, we will have to be careful not to lose this diagonal, Bruno, because of 2 layers of strength. That's the other point. The other point you can see at 10 o'clock and 11 o'clock, there is also calcification in neoatherosclerosis. So neoatherosclerosis is the main mechanism of in-stent restenosis, lipid and calcified. And interestingly, because we know the history of this patient, and we know that it's a 3.5 stent which have been implanted many years before, and you can see on the, you can appreciate that the diameter is nearly 3 millimeters, so there is a little bit under-expanded stent, which is a mechanism who underlines the in-stent restenosis.
So to summarize, we have neoatherosclerosis for in-stent mechanism, LAD, and we have the diagonal which is covered.
Absolutely.
Okay. So now we move to the left main.
The left main, and you can appreciate, and we heard about the black box under 6 millimeters square, and we are nearly in the left main, nearly 7.5 to 7.8 millimeters square in OCT. And so far, I think the main point for this patient, this old patient HBR, is safety. And we have MLR on the left main nearly 7.5 to 8 millimeters, which is not normal, but this is not critical. And so with Bruno and all the team, we decide to treat it medically and to avoid a strategy of angioplasty in this old patient on the left main.
So to summarize, we'll just treat LAD, in-stent restenosis, taking care of the diagonal, but we will not treat the left main with the result of the intracoronary imaging.
Absolutely, absolutely. But this point is very important. But Valeria said we need a proper landing zone. So if we go on the distal landing zone, there is a lipid plaque at the edge of the stent. You can see it from 6 to 11. There is an important lipid plaque, so we will try to avoid a plaque burden at the distal edge of the stent. But if we go also on the proximal part, on the proximal LAD, we also face from a lipid plaque on the proximal LAD. So the strategy will be to only treat the in-stent restenosis, try to stay on the LAD, but keeping in mind that there is a high burden of lipid in the distal and proximal edge.
Okay, so I think that we can move now to the treatment. So what's the strategy to prelate or to prepare due to the mechanism of the in-stent restenosis?
What we choose is we should not lose this diagonal. Okay, this diagonal is important, and so we first going to treat by a kissing to be sure that the strut from the first stent will be enough open to avoid a coverage with 2 layers of strut of this diagonal. Does it make sense for the panel, or any comment on the OCT or the strategy? Ça, c'est le combien?
I think it makes sense, Benjamin, and as we said, also the timing of restenosis was also a good argument to think that it might be neoatherosclerosis. And consequently, as you said, that will be probably a good indication to put a new stent, while with earlier restenosis, we could have considered other options, but clearly not in this case.
I think that also the rationale to treat the diagonal first and to do a kissing, that we don't have the information about a possible kissing during the first intervention. So I think in this kind of situation, probably doing a kissing is a good option. And you see there is some difficulty to cross. So it means that probably there was no kissing during the first procedure.
And Bruno, which type of wire do you use for both?
Okay. I think for the LED, it's a run-through wire. And Benjamin liked to use the Fielder XT in order to cross the struts of the stent.
FC.
So FC.
Fielder FC. I like this guide wire to recross the strut. I think it's a perfect. Of course, you have to be, for the younger interventional, you have to be careful with the tip of this wire. But for recrossing, it's a perfect wire.
Yeah, Davide, you had.
And now we advance the balloon in the diagonal is a small one, but it's just to open. And we want to avoid to have a dissection in the diagonal and to complicate a little bit after the procedure. Okay. So it's a 2-0, it's a little bit on the side, but it's just to really to open the struts of the stent before putting a new stent. And for the LAD, it's a 3-0. It's a 2 non-compliant balloon in order to stay on the safe part and not to go to very high diameter.
Yeah, okay? Bruno, we have questions from Davide. We have questions from Davide.
Now, let me just underscore, sometimes in elderly patients, we are hesitant to use OCT because we are afraid of the contrast, etc. But in this case, it shows how it simplified the procedure more than making it more complex, because there is less metal in the end as a decision, and we discovered the 2 mechanisms that are likely the reason for this PCI failure, neoatherosclerosis and underexpansion. So because the OCT is on the table, I guess that we will also see the result and optimize.
You're right, it's counterintuitive. Sometimes using imaging makes your procedure simpler. So that's a very important point.
Just a question, Bruno, concerning the length of the balloon of the diagonal. The question is...
it's a long one, it's a 20 millimeter.
Yeah, and the question is why?
20 millimeter. It could be a short... why it was the preference of Benjamin to be... but I think that a shorter will be very accurate. Yeah, the pilot is deciding.
Yeah, I like to use 20 millimeters balloon for the side branch. I think it's very stable, more than the 12. So, but again, it's a personal
preference.
Habit. Yeah.
I want to make a comment. That, in the OCT was clear that there was no side branch opening. It was a full jailing of the side branch, and this is remarkable because this illustrates how important it is to do the procedures properly for thinking in the future, because if you have a restenosis in the LAD stent and you don't have a side branch opening, maybe you have a compromise of the side branch, and this may also come occluded. Then I think it's always important when the diagonal or the side branch is large like this to finish with a side branch opening and kissing something, thinking in what's going on in the future. Yeah.
And it's going a little bit against what we used to do more and more.
Yeah. Probably I will do another inflation down to the stent.
This is not enough for the distality of the stent, so we will take...
but we don't need to do kissing, just the 3-0.
Only the 3-0, yeah, absolutely.
And Bruno, the distal part of the lesion is outside the stent. It's proliferative, the restenosis, or it's just within the stent?
We have some disease beyond the stent. As mentioned, Benjamin, there was some disease, and there is no free landing zone without any atheroma. So it's complex to say that here to have a free landing zone without any disease. It's a quite diffuse disease for this patient, like for also the bifurcation. When you look at the bifurcation of the circumflex, it's a quite long and diffuse disease.
As Bruno said, there is a lot of... you can see it's not enough prepared because the 3 millimeters balloon non-compliant that we use first have some difficulty to cross this lesion. So maybe I will need to take another one. No, it's
okay, it's just a matter of... Okay. You remove it a little bit?
Right, test, please.
Okay.
Okay. Okay. So another point is you've seen that left main is disease, is not critically, but it's a disease, so I have to avoid to make injury with my guiding catheter. And there is a lot of friction in the guiding catheter with the balloon, so it's a safety point. Try to avoid to tackle
Maybe
this,
I will do a higher inflation, just here. Yeah.
Please, oh no.
Okay. Here. Okay, I like to have the balloon nicely inflated like this.
And Bruno, as you say, when we have...
question that...
Sorry, please, Benjamin, please.
Yep. No, please, Thomas. I
think it's good illustration that when we have stent failure, we have to look for mechanical also explanation, and you nicely show that there was some degree of stent under expansion, and then you optimize it before placing and just another stent.
Yeah.
Absolutely, and the question on this mixed neoatherosclerosis, which is a lipid and calcification, does we need a specific plaque preparation? Do we need other tools than non-compliant? And for that purpose, we propose with Bruno, to make a run of OCT to be sure that we have enough prepare our in-stent restenosis before going to another stent, because the risk is on this underexpanded stent is to go for another underexpansion of the stent. So I think we are pretty concerned about the kidney disease of the patient, but I think we will need another run of OCT to be sure that we have perfectly prepared this lesion.
Maybe we will do an angio to see what we have done.
Just a question from the audience. In this case of in-stent restenosis on the LAD, do we prefer to use a semi-compliant balloon low pressure or an NC balloon high pressure?
Definitely, when I'm facing in-stent restenosis, I prefer to go with the NC balloon in order also to have a high pressure and to be sure that the stent is better expanded.
Thank you, Bruno.
Okay, so angiographic is much better. We can see that on the distality of the stent, there is some, again, some narrowing, but we keeping in mind that at the OCT, there is an important plaque burden, lipid plaque burden at the edge of the stent. So if you agree, Thomas and Jean, we will go for the OCT to control that the preparation in the stent is enough.
Yeah,
and probably we will have also to answer another question, because after this predilatation, I have the feeling that maybe there is a proximal dissection, but we will control it. It will change our strategy.
It will change, and if there is an ostial dissection of
the LAD,
ostial LAD, but we'll see.
Proximal LAD,
we'll see. Yeah,
certainly.
We'll see.
And
you know, sometimes the angiography also is useful.
But the beauty of OCT is that you can have both the angio, the acquisition, and then the imaging just after.
Yeah,
exactly.
And Benjamin, or Bruno, for this specific run, you speak about, to assess whether plaque modification has been optimal or not. What you will look at for this specific intracoronary imaging run to decide?
Yeah, I will especially see the MSA, Thomas. The MSA after preparation, if we have enough. We will not seek for fracture of the calcium or specific thing, only the MSA in the stent, which will be probably appropriate to put another stent.
And crossability of the device looks really nice. Huh?
I think one of the key points of the
sometimes
CT here at this stage is really the length of the stent as well, because of these shoulders of the balloon that may have impacted on the landing zones. So if we have dissections, we will go for the longer stents, otherwise a shorter one.
Could be longer.
Okay, always in this cranial view, the trunk, the left main is worse than the other one, but we have to trust in the OCT for the left main. But of course, when you see the angio, so maybe we can share the OCT on the screen.
Okay.
Okay. So would you be kind to make the stop on the interesting point, please? So this is, again, this is a new OCT. This is not a true core registration that you are on the right. This will be on the second generation. However, you can nicely appropriate see in the stent that we have improved, for sure, 1.1, more than 4.5 millimeters square. There is blood swirl, which...
we are still inside the stent here.
We are still inside the stent. So
we are still inside the stent.
And if you can go, Giovanni, on the ostium of the LAD, please go back a little bit.
Left me, yeah.
Yeah. Giovanni, if you can go on the ostium of the diagonal that we see. You can see the wire at 7 o'clock up, so the struts are well open.
Yeah.
So that's a good point. So now I think we are pretty convinced all that the MSA is enough to go for a treatment in this stent. However, we will focus on what you say on angiography and go on the proximal LAD to be sure that there is no dissection. But I'm pretty convinced, like Jean and Bruno, that the ostium of LAD there is a dissection. You can see nicely at 11 o'clock. There. the experience. And if we go on nearly the bifurcation with the left main, do we have enough place to treat? And yeah, but it changed our strategy. What do you think, Bruno? What do you think in the panel? For my position, I think we will not have the choice to not treat the left main because we don't have a proper proximal landing zone. What do you feel?
Yeah, well, you are more experienced than me for the evaluation of the intracoronary imaging, but effectively here it will be interesting to know if they have the space or not to put a stent before the left main. And if we don't have the space, we have to treat the left main.
Yeah. Giovanni, can you go just at the bifurcation of the left main, the distal bifurcation, again, frame 1? So this here, okay?
Yeah.
So what do you think? Do you think that this is proximal landing zone is enough safe to go for only strategy, LAD strategy stent? I'm not sure of that.
Valeria will provide a valuable opinion.
Well, I think it was challenging from the beginning finding a healthy landing zone in this proximal LAD. And we also saw from OCT clarified very well that indeed there was a high lipid burden in the proximal stent edge. So what happens when you dilate with a non-compliant balloon, with balloon in general, sometimes you have slippage of the balloon. Also, especially in this neo-atherosclerotic calcified lesion, so it may happen indeed that the balloon slipped proximal or distally and may create a dissection, and that a risk you take. I don't see a healthy landing zone here, so I would proceed for the left main.
Okay.
Yeah, agree. And Bruno Benjamin, can we reassess the left main maybe on this run?
Yes, please go ahead, Giovanni. Would you be kind to go upper on the left main?
It's not to have a second.
This time
not to have second
we'll
argument.
have to take a decision about the second wire because we have the wire in the diagonal and probably we have to decide do we leave it in the diagonal or do we put it in the circumflex because now we have to treat the left main.
It's about the same. We are still above 6, but it's borderline. It's without landing zone in the ostial LAD, I think makes sense to cover the left main.
To nail a stent in the ostium of the LAD in presence of plaque in the lead main, in the distal lead main, the mother extension is always a bit complicated. In that case, you take it, you cross over the lead main and you use the lead main as a landing and you treat the plaque. It's not
so
treating something
the decision
severe,
is made.
The more effective.
And Bruno Benjamin, would you consider to do predilatation of the left main and the very proximal LAD if finally we'll take a long stent covering the left main, or you think just the predilatation of the, let's say, the culprit lesion we identified was enough?
Yeah, I'm pretty convinced, Thomas, because we have seen that it's more lipidic in the ostium of the LAD, so I think it will be enough to tackle it. If you agree, I will just remove my diagonal wire and try to place it in the circumflex, Torker, s'il vous plaît, to protect. But there is an important angulation on the circumflex. Go.
So now you put the second wire, which was in the diagonal, to put it in the circumflex because the territory is larger. We are in 6 French, and we are not in 7 French because we are not sure to treat the left main, and we feel that if they have a very diseased left main, probably to put a 7 French could be an issue with the damping of the pressure. Okay.
So interesting real-life case. Huh? This is real life. This is complex decision.
So now the stent that we put, what size and what length?
So this is important coming from the OCT. We have a distal. Giovanni, can we go back on the distal zone? We are pretty convinced that on distality, on mid-LAD, we are on 3 mm stents. If we go, it's 2.6 in luminal. We cannot appreciate the EEL diameter because it's too diseased. So on the lumen it's 2.6. So you have to increase by 25%. So we will go on a 3 mm diameter stent. And if we have to tackle all the lengths, so Giovanni, can you make a measurement from the mid-LAD to the ostium of the left main? Maybe we'll be more on 40 millimeters, and we will need long stents. Let's see.
the technical point is the 3 mm stent enough in diameter for the left main? Because we'll have to expand after this 3 mm stent in the left main. And what is the size of the diameter of the left main? We know that the 3.0 can reach 4.5, but it is over 4.5. Maybe we have to consider to put 2 stents, no? What do you think?
I think we can nicely, this is in the interest of the Ultimaster. No, Giovanni, can we have a full measurement? Yes, please. Count 44, yeah.
44.
44 millimeters. So we have a platform that can be deformed. If you talk about the platform of 3 millimeters, we can nicely deform it to 44.5 to 5 millimeters, the Ultimaster Nagomi. So I will rather take only one stent, Bruno, because there is also in stent restenosis, so try to avoid multiple layers of struts and to increase, according to the OCT, the diameter of the Nagomi stent from 3 to 5, according to the OCT.
So to be clear, not all the stent, or not all the 3.0 mm diameter stent can reach 4.5. Huh?
On va se repasser en angio, s'il vous plaît.
So that's the strength, I think, of the Nagomi. And what is the size on the OCT of the left main, Bruno? Benjamin, you say it's...
What's the diameter of the left main? Can you refresh for us the diameter of the left main, please?
It's at least 4.5, yeah?
Yeah, between 4.5 and 5.
At least. Yeah.
It will be suitable
Can you
for
just
the overexpansion of the Nagomi. So that's... and as you said, it's not the case for many three-hole stents. Huh?
Oh, okay, yeah. Okay.
So you can nicely see that
very
the long
nice
Nagomi is crossing quite easily. So now we will
It's a 44 millimeters.
Yeah, 44.
Length.
So we will check in distality if we are in the healthy zone that we want to reach. So please, Elsa, make a test, Bruno.
Okay.
Up. So for the distality, it's okay. And now
we have to go in LAO in order to separate the ascending aorta.
Yeah, maybe just to explain, you go in eleocranial because it's usually the best for the ostium of the left main. Huh?
Yes, you see here we can see the separation between the aorta, and nice. Probably maybe will.
That's okay. Yeah.
Yeah, I think
it's okay because the stent is inside the marker.
So, Bruno, if you agree, I think the position is good.
Okay. So let's go.
Nominal pressure is 12.
So I go with 12.
Or 11.
Yeah.
So there's nice expansion of the stent.
And a nice bubble inside the balloon.
What is the pressure?
Okay.
It's
12. It's 12. I don't want to go too high pressure because I don't want to have a distal dissection, so I go nominal at 12. Probably we will go back with a 3.5, maybe for a proximal LED before the diagonal, and with a 5.0 for the left main. First, we have to check the patency of the different side branch. That is the circumflex, the main one, and then to look at the diagonal and do the pot.
And of course, we have to be very careful, try to avoid a stent failure with the guiding catheter.
And you see, Benjamin is doing very gently. He's not removing very fast the balloon. He's taking, especially when we have to do that with a long balloon, where there is more friction, more tendency of attraction of the guiding catheter. So you have to take time. And here the balloon is inside. Sometimes you deflate. You see, he's doing that very gently. He pulled back his guiding catheter in order to avoid any damage of the proximal tip of the stent.
That's an important,
a beautiful demonstration.
An important moment.
Yeah.
You have to be very careful not to be attracted by the jail guide wire. 5x8, please, for the pot on the stent.
And Bruno, Benjamin, because of some degree of calcification and stent failure as well, would you also consider what we can call the dot that sometimes we do also? It's to optimize the distal part, of the stent with a higher pressure?
Yeah, probably, yeah. You are right. Okay,
absolutely,
maybe
Thomas, we will do it.
We have to do multiple optimization here.
Again, yes, absolutely. Again,
but the
this is
first
not-
one is the pot in order to be sure that after there is no difficulty to recross toward the left main. Maybe we can do an angio to see the patency of the circumflex.
But it's true that for the people in the room, when you have done this, we know definitely that in the left main, the stent is not is undersized, not well opposed. So the first thing to do is to do the port with a 4.5 millimeter balloon in the left main, and then we will be sure to have a good apposition. And then we could work on the side branches, on the distal LAD, on distal part of the stent in LAD.
So we have seen on the angio that the diagonal is patent and also the circumflex is patent. Okay. So now you will advance the non-compliant balloon. Okay. Okay.
What the size of the
gently.
balloon?
5-0.
It's 5-0. Okay.
Yeah. 5-0. We will check it to be sure that we are not too distal. Test. Okay, I think I can advance it a little bit.
Yeah.
Of course, I'm not perfectly in the. Okay, please go ahead.
Okay.
Straight forward there. It's great.
So we try to be just at maybe you see you pull back a little bit.
Yeah, deflection. So you can appreciate that.
Okay. So now we have opened the optimized, the left main. Probably because we are.
Okay, go ahead again.
I hope it will not. It's like a. Okay, it's better. Probably we can go back with a 3-5 because it's maybe too big for the distality. And now we will do the same. That is to remove the balloon and to be cautious with the tip of the stent. Okay, perfect. Yeah. So I think that we can go with a 3-5, at least 12 millimeter non-compliant balloon.
We will recross the struts of the circumflex first. So can I have another field?
Oh, you don't want to optimize the proximal LED? No?
We will do it.
Yeah.
We will discuss it after. Just I want to get out this wire gel. So a fielder FC, please.
So maybe we can do an angio? Okay.
Yeah.
Okay, but the osteomial circumflex is correct, huh?
Yeah,
absolutely.
We don't have any problem.
And sometimes
I think the diagonal is patent.
Bruno, Benjamin, for the pot, do you feel that sometimes, the system of stent enhancement, stent vist or stent boots can also be useful? Sometimes, I think in this case, you have beautiful view to position the pot balloon, but it's true that sometimes it can be useful.
Yeah, correct. That's perfect. Here you will try to recross toward the circumflex. Sorry. So the tips is to go inside the LED, if possible, with a loop to be sure that we are not under the struts of the left main stent, and then to pull back the wire and to jump in the circumflex. So as you can see, so here is the aorta.
So the difficulty is to be coaxial with the guiding catheter.
Because there is a gel wire. But the circumflex is perfectly patent. Huh? You
have to be very gently.
So what say Bruno, it's of course important because we have the gel wire in the circumflex that we could not intubate the left main with the guiding catheter because of the gel wire. And so this increased the difficulty to place the wire, the third wire in the left main. Okay, now it's done.
And Benjamin, as you did for the diagonal, and you use the fielder again to recross the strut, if I'm not wrong.
Yeah.
That's
it's still a field. It's the family. Yeah, it's the fielder FC.
Yeah.
When you have such a
bend,
it's coming.
Yeah. It's challenging.
Yeah, it's going, but you can see that there is you can see the angle of my guiding catheter, which is attracted by the circumflex guide wire. And as Bruno say, the circumflex is patent, and maybe. I will remove the.
No, because when you say that, you cross. You see, maybe you cross.
You just support yourself a bit.
Yeah. But effectively, as the circumflex is patent, you have the possibility to remove the wire. For sure, it helps you to recross because it shows the pathway, but sometimes it's also a limitation, and you can just work with one wire and to recross thereafter, and then to improve your intubation.
Okay, so we are now in better position, and we'll try to make a better angio.
Okay, let's see.
So immediately you see that the guiding catheter now can be pushed inside the left main, and to have a coaxial access of the guiding, the distality of the guiding.
Honestly, the osteum
maybe we have to look
is really nice. Huh?
Oui, la petite branche en bas.
Yeah, absolutely, Thomas. And there is no destabilization of this osteum, keeping in mind the key term that we use at the beginning of the live case is safety. So the realization of a kissing could be discussed, or not.
That was exactly my point, Bruno and Benjamin, to say that.
Maybe what we can do is to optimize with a 3.5 non-compliant balloon and then do the OCT. But during this time, I think that you can have a lecture, and so you have time to do the optimization of the proximal LAD. Yeah. And then we do the OCT and we come back to you with the OCT recording to see if we have to do some work more on the left main or on the left.
Yeah, and before the lecture, we can ask all the members of the panel what we do for the osteum of the circumflex. Balloon or nothing?
Okay, perfect. Okay, we have time you have time to think of it.
I would ensure that there are no struts in front of the circumflex. It's too much an important side branch, so I would balloon it.
Okay.
Honestly, I almost always do kissing for the left main, but for this one, looking at the angio in this specific patient, maybe I will stop.
Valérie?
I agree with Thomas, indeed. I mean, opening the struts towards the circumflex is really to allow further intervention. Do we really want to go for further intervention in this patient?
I always do side branch opening. I want to leave the door open behind
for
me.
the future.
And you have a bifurcation in the circumflex which is diseased.
Yeah, but we decided to leave it alone. So I think if we don't treat the distal circ...
Maybe in the future, in a few months, it's 90% with symptoms, and you have to go to the circ to treat it. Then I prefer to do side branch opening in the circ.
That's why we
maybe because I am the oldest guy here in the panel, but I will leave the circumflex like that. But, you know, it's interesting to discuss. Nobody knows.
So maybe, Jean, while they are optimizing proximal LAD and doing the OCT run, we can ask Valeria, because they already nicely mentioned the Ultimaster Nagomi stent they use and the mechanical overexpansion capability. So probably it's a good moment for Valeria to update all of us about this specific stent platform.
An update on Ultimaster studies. And this is the most recent technology by Terumo, indeed the Nagomi drug-eluting stent, with an inherited technology, open cell to link design from the previous Ultimaster, but also shorten struts and beds width, which increase flexibility. We have three platforms with increased expansion capacity and also a broader lineup of Ultimaster DES. The new hydrophilic coating for enhance deliverability. And we talk about expansion capacity. We have to bear in mind that the platforms from 3.5 to 4.5 allows an expansion of the stent diameter up to 6 millimeter 25. And that's particularly important in the setting of bifurcation cases and particularly relevant in the setting of left main. And also the 10 crowns in this platform, so the largest platform, improve expansion in large vessels. In the setting of left main, not only provides better apposition, but also a more uniform vessel coverage, what we call scaffolding. And the Nagomi DES has been the objective of an important registry dedicated to complex lesion, which just completed its enrollment. 3,000 of complex PCI patients were recruited. As you see here, complexity goes from anatomical complexity to procedural complexity, but there was also an a specific focus on subgroups of high bleeding risk patients. And these results have been just presented 1 hour ago about HPR patients, which were represented in 45% of the population enrolled. As you see here, stent length and multivessel PCI as left main stenting were well represented in this population, as we saw indeed in the case from Toulouse. We have to acknowledge that these HPR patients have a less favorable profile, more diabetic, hypertension, more atrial fibrillation, prior revascularization. So these patients are complex from a high bleeding risk perspective and ischemic risk. But we have been reassured that also in this complex subgroup of patients, we have excellent short-term clinical outcomes with a 30-day TLF rate of 1.4% and stent thrombosis rate of 0.3%. And we are expecting the primary endpoint results in 2026. But these HPR patients are particularly relevant because, as we saw in the Nagomi complex, they represent indeed 45% of all the population, all the patients that we treat all over the world. And if we look at the trials, dedicated trials to HPR patients, we have to make also some consideration. On the top, we see all the trials which compare different DES platform in the setting of using the same DAPT regimens. These trials are not really informative about the safety of DAPT, of shortened DAPT, more about the choice of the DES platform. On the bottom, we see all the trials instead, which compare different DAPT regimens with the same DES platform. And when we exclude the trials which enrolled a historical cohort or an objective performance goal, we see that the only trial which completed results was the master DAPT. And indeed, this trial showed that in more than 4,000 HPR patients, 50% presenting with ACS and abbreviated DAPT proved to be non-inferior in terms of NACE and superior in terms of major or clinically relevant bleeding as compared to non-abbreviated DAPT, with or without anticoagulation. But how about complex procedure? Even in the master DAP, we have a sub-analysis about patients with a high ischemic risk, so undergoing complex PCI, and these results were confirmed. There have been multiple publications from the master DAP focusing on different subgroups, but what's more important is that the results of master DAP actually served as evidence for the guidelines recommendation. There was only master DAP, the reference to allow the guidelines on acute coronary syndrome in 2023 to say that we can go in HPR patient for 1 month of DAPT. It may be considered with a class 2B recommendation. And later, the chronic coronary syndrome 2024, allowing a shortened DAPT, so 1 to 3 months, class 1A recommendation in HPR. Thank you.
Thank you, Valeria. So probably before going back to Toulouse, Jean, we can ask Rasha to have analysis of the angiography that we've seen during this first part of the live case.
Thank you so much, Thomas. So very interesting case, and it kind of highlights how imaging really changes your strategy throughout the procedure. So if you look at the first image that they got of the left main, and the whole idea is to get the MLA, it was 7.8 and decisions not to treat. And one probably theory why we're seeing it worse in the cranial view is probably we're looking at it from one of these angles. It's an elliptical shape, as if you're looking at it from the caudal, might be from this angle. Now, moving on to the ISR segment, you can clearly see that the stent is overall, I know they mentioned a little bit of under expansion, but overall it's 2.95 in terms of diameter. And here's where the stent is. But clearly there's neoatherosclerosis. And this particular view looked like neointimal hyperplasia, as if somewhat more uniform. But then if you look at other segments, it was clearly neoatherosclerosis with mixed plaque and a mixed plaque here, and also a segment of calcium right here. They did point out that this is where the ostium of the diagonal, and they wanted to make sure to not overlap with the stent with the initial strategy, which changed. Now, moving on to the next image, and this is where imaging was extremely crucial. So after they did the ballooning, they did an OCT run, and you can clearly see the dissection right in the proximal LAD. And it did not end here in terms of imaging, changing your strategy. The decision when to treat, they also looked for a good landing zone, and in this case, there wasn't a good landing zone at the proximal LAD, which I'll show in a second. So this was the proximal LAD, and you clearly see how diseased that segment is, and the lumen is also small. So it was the right decision to take the stent all the way to the left main, and we'll see the final results in a second.
Thank you, Rasha. Thank you.
So we can come back to the cath lab. Bruno, Benjamin?
Yes?
You're
Do
online.
you hear us? Yes?
Yeah.
Yes.
Okay, so we will explain what you have done, Benjamin.
Yeah, so we heard about the dot and the optimization with the 3.5 millimeters balloon that you can see there. And
we go distally also.
And we go distally, of course, to optimize in the stent. And we perform the OCT. So please, can you share the OCT? And first of all, you know that when you perform an OCT on post-PCI, you have to first check the distality. And Giovanni, if you come back some frame just below, you can see that it's distal part of the stent, and there is no dissection.
No distal dissection.
No edge dissection. So that's the first point. And if you come back slowly in the mid part of the stent, you can nicely appreciate that we have a lumen which is much more than 4.5 millimeters square. We have nearly 6.8 to 7.2 in the stent. Mm-hmm. So for the purpose of the treatment of the in-stent restenosis, I think the job is done.
Okay.
If we go also, interestingly, on the ostium of the LAD.
And we see here the two layers, huh?
Absolutely.
At the OCT.
On the diagonal, sorry, Giovanni.
The diagonal.
You can see that I think we did the first good choice to open the previous struts, and you can see that there is only one crown just in front of this diagonal, and so far we will not go for another kissing in these cases. And now, if we go on the zone of interest on
left main.
On the left main, on the stent, you can appreciate that there is one crown of struts just in front of the circumflex, like you can see at 12 o'clock. And when we go back again in the left main trunk, and you can see that there is a perfect apposition and a MA sec nearly 10 millimeters square. So we jump from 6.4 to 10 millimeters square with a good apposition and a good expansion of the stents.
Just to refresh me, because for the LAD, what is the target MSA that you want to reach? Because you say 3.4 is okay, but what will be your level of decision? What is your...
The threshold of treatment? Yeah, we say 6 millimeters square. And it's a black box, you know, and sometimes we have to combine physiology and anatomy. But in this case, I think the main choice of treatment of the left main was the ostium of the LAD, which was imperfect for a proper stenting of the LAD. Okay?
Okay, so now we have done this OCT, so we know that we don't have to go back to the LAD stent. We don't have to go back to the left main stent. And so the decision is, do we need to do a kissing, yes or no? That's the final question. You want to do a new angio in this view, maybe? Okay, ready?
Sorry, I'm not properly in the left main. So in
not
terms
so
of
bad,
angio, it's not so bad, Bruno.
Yeah. Because when you look at the proximal LAD, there is also some, just at the ostium, there is also some disease. So I'm afraid that doing a kissing could destabilize this plaque. Let's see.
It's an open discussion, because...
Yeah, we have the privilege to have a lot of experts, so we will follow your... because we don't know.
Bruno, Benjamin, we discussed that within the panel, and probably, Jean, we have also insight from the room. And honestly, we had different views on that. And one of the points from Chema was to say that there is distal lesion in the circ and in the marginal. Yeah. So probably for the future, it could be safe to do the kissing and to keep the door open in case the patient is coming back in few weeks, few months, hopefully not. But then to make the life of your friends easier.
That's okay.
Absolutely, and I think it's a very important point. Maybe we can do a kind kissing. Maybe we can slightly undersize the balloon on the circumflex. So maybe we will use a 3.5 for the LAD and a 2.5 for the circumflex, just to open the crown, okay, and to be sure that we can go on the circumflex if needed in the future. Do you agree with that?
Yeah, it sounds like a very good compromise. Huh? I don't know what you think. Yeah,
Maybe you have to replace your wire, no?
Personally, I agree. If you take a 2.5 balloon just to open the strut, why not? If you use a balloon in order to have a perfect opening of the vessel, I think
then you will put a stent.
You could transform this single stent implantation in a TAP technique. You know, that's this again in an octogenarian patient. It's a high price to pay.
That's exactly what we want to avoid.
If you want to do it, my advice would be to take a very small balloon in order to just open the struts.
And for this
could be discussed.
To continue on this in this discussion, we in this octogenarian patient under oral anticoagulation, if we can stay with only one stent, it's always maybe better in order to stop the DAPT a little bit earlier.
What you mentioned, John, is what exactly we do in the side branch opening. It is just to use a balloon that is 0.5 millimeters less than the balloon you could use to treat the osteoulcer in case of being diseased. Because you only want to open the struts, but not to injure the vessel. Because if you injure, you have dissection, maybe you need a stent, or maybe you elicit the restenosis process. It's just with the imaging, you can calculate the balloon that is just for side branch opening very gently and smoothly. Yeah.
The concept of undersized
so you
balloon
take a
for the side, I think
2.5
it's a good one.
Which one? Which balloon do we are here?
So I don't want to push too much the operator, but Bruno, we work more than 15 years together. He knows perfectly what I will do in this situation.
Yes, I know.
No, but I think they found it's a good compromise between aggressive kissing and not to do it.
Huh? You see, he tried to cross with a non-compliant balloon. That's explained maybe his difficulty. So I will maybe switch for a semi-compliant balloon.
Is it a new one or the one you already used? That's it.
No, we already use it.
Yeah.
That's why maybe.
I think in this case, after challenging PCI, usually I just take a new one. That's
yeah, we could 2.5 by
10 is enough, no? Would you want longer?
No, a longer one.
15?
15.
15, the 5.
Up. And especially you have to be very gently and not try to force to cross the strut, because if not, you can undergo for stent failure. So, and if it's not, I will change the strut of recrossing.
That's another solution, yeah. That's the difference with Jean's strategy. With Jean's strategy, we have finished the case. Huh?
Yeah. But we try to follow the rules of the European Bifurcation Club to try to do the kissing with non-compliant balloon. Huh? So let's go a little bit. It doesn't cross, huh? Interesting. So maybe I will have to change
the cells.
The cells of crossing. Yeah.
Yeah, I will not force because it's 2.5 semi-compliant and probably.
Be very gently, yeah. So we will try another things. Give me a smaller balloon of 2 millimeters, just to see if the two cross, and we will go after higher. Okay. And if it's not, I will change my cells of crossing.
And Valeria, would you consider just semi-compliant in this case? We know that the profile, sometimes it's easier, or you will change the cell as proposed by Benjamin?
Well, honestly, at this point, there was a 2.5. I mean, it should have gone quite easily towards the circumflex. So I would consider indeed changing the struts. Yeah.
Yeah.
Ça, c'est quoi?
2-0. Let's see.
If not, we will change.
What do you have now, Benjamin?
A 2.0 millimeter balloon.
Semi-compliant, just to make the path, and if not, I will change the crossing cells.
Yeah, you see, still a difficulty. So it's not normal.
No.
So, if you agree, I will change the cell of crossing.
Okay. So at this moment, when you want to change the cell of crossing, do you put to still stay with you take a third wire, or do you?
No, I will take the same one.
The same one.
Yeah.
So you remove this one and you will try to replace it,
Yeah,
correct?
absolutely.
Okay, so I will.
So, any advice, Jean, Thomas, Valeria?
No, the advice was to recross to another position.
Another cell.
Yeah.
Cœur, s'il te plaît.
Dr. Kerr.
Now, would you consider also to change the wire in case this one recrossing another strut doesn't work?
Test.
But Thomas,
Another wire.
so
Yeah, sorry, David.
we are changing the strat, but is it shameful to change the strategy at all and go to Jean's idea that if it fails, we stop like that? Because I think it depends on how much difficult it is. In this patient, we may jeopardize.
Yes, more contrast, more. Yeah.
No, of course. When you are hesitating between kissing and not kissing, sometimes the case decide for you. So
Exactly, that's my point.
Yeah.
Allez.
It's a signal.
Le 2-0.
Allez.
So we recross. We hope it's not the same cell.
We will see. If not, maybe
let's come back to
we heard your advice and to be wise, huh? And maybe not to search for.
But I'm sure,
Best
Benjamin, you
theory
follow the
best.
discussion, and a significant number of the panelists were in favor of not doing kissing in this. So it's both options, I think, are really valid in this case. I think there is no absolute truth.
Yeah, absolutely. And what I really want to avoid, Thomas and all the panel, is to have a stent failure on the left main,
Of course.
just to cross this strut, okay? Because it would be a pity to have a longitudinal compression or a crush of the left main stent only to open on this circumflex. And you see, I got the same issue, huh?
Yeah.
Interesting. I'm sure that I am in the lumen. I'm not under the strut. That's not possible because I cross with a knuckle on the left main, and there is something.
And the stent, the balloon is inside the left main. Huh? So really, it's at the level of the bifurcation.
Yeah, but there is very difficult bend that we've seen also on the
Yeah.
slider. There is almost
And maybe some calcification also.
Support provided by the
problem.
catheter is poor. It's continuously going back.
Yes.
Maybe,
Yeah. That's correct.
So I think sometimes we should to be wise.
Yeah,
Okay.
yeah.
But what I will do before is to go back with the 5-0 because we have to do some, and to be sure that the stent is really well posed at the level
Yeah,
of the.
absolutely. That's a good point.
And
Because we have done some manipulation with the balloon.
5-8, 9.
5-8-9. So we will finish with another pot in order to be sure that the left main stent have not been a little bit damaged by all our maneuver. As mentioned, Benjamin, what is important is the stent deployment at the level of the left main.
As Chema mentioned, we don't have ideal support probably with the guiding. So in this case, probably it's wise to stop. But in case we really need to do it, what we can do is also to anchor the guiding with a small balloon in the proximal LAD, which will give more support across through the circ. But I don't think we have to use such complex tips here in this case.
Yeah, that's a good trick. Huh? When you have this kind of problem, you place a balloon in proximal LAD, you
anchor everything.
Use this balloon as an anchor, and then you can push.
Test.
But again, octogenaric patient,
benefit.
I will not change my strategy, single stent, and then the most important in the auditorium is the safety of the patient.
Yeah.
Okay.
No, just the tips
the
to be
goal
used.
Was left main LAD. We have done. The result is perfect. The rest is, accessory.
Now the
So
tips
safety first.
of anchoring, Jean, probably to be used when you have really side branch loss or really need to have access.
That's
I think that's a good tip.
Here,
But in this case, probably
and geographically it's good.
It's too complex, I think. I agree.
And for our young colleague, I will say it's possible to cross with a balloon, but not with a stent. Huh? Don't do it to cross with a stent.
Yeah, you can imagine if you have a dissection.
Rafi?
Beautiful.
Okay, so
Fine.
Yeah.
I think it's good.
Yeah, it's good.
We don't want to change our mind. We talk about safety. Okay, I can insist to cross.
Yes.
It's technically feasible. We have multiple tools to try to cross.
Oh.
As you say, Thomas. But do we have to do it? I'm sorry, not convinced. So if you agree, I will check on the cranial incidents, and if the results on the LED is good, I will stop the procedure at this time on this old patient. What do you think?
All the panel and even I'm sure the room is fully aligned with what you suggest, Benjamin. I think it's to keep it safe. The left main LED job is done, result is ideal, and I think that's more than enough for this 85 years old gentleman, I think.
Rafi?
Yes.
Okay, perfect.
Perfect.
Yeah, it's perfect.
So there is no issue on the left main. The left main is treated. The circumflex is patent. We have well opposed the stent on the left main. I think on the LAD the results is good. The instant restenosis is treated. Okay, let's keep. I think it's a wise take-home message to stop
Bruno,
at this level.
and Benjamin, we started, I think it was the first question to Valeria on do we need to have a full revascularization or not? This is a perfect demonstration that we did the right coronary artery, with good result. You did the left main LAD, good result. And for the bifurcation of the circumflex, there is a room for medical treatment. For me, it's clear.
Yeah, I'm sure the patient will be free of symptoms now, and that's exactly what we want to achieve in stable
And when you
patients.
look at the circumflex, it's a quite diffuse disease because the osteum is not perfect, and then you have a long disease toward the first marginal and then to the second marginal.
85 years old patient. So I think it's also a good message to say that technically we can do it, but do we have to do it? We are not convinced.
What's impressive angiographically is the size of the left main. When you compare to the size of the angiography left main at the beginning, we have this on the left side. Look at the difference. So this is really a great result.
But that has been achieved by imaging, because if you rely on the angio, probably the stent would have been a bit smaller, expanded in the left main. So that's
So, bravo.
Thank you.
Thank you, congratulations.
Great job. Thank you.
Thank you.
Thanks to all of you. I think we've seen a beautiful example of a challenging PCI in HBR patient, and also because it's nice to show what we can do, but it's also very important, especially for our younger colleagues, to see when to stop and when to be wise in this kind of frail HBR elderly patient. So again, thanks a lot, and thanks to Terumo who support this session. It was a pleasure to prepare all that together. And wish you a nice day and a beautiful meeting here in Paris. Thank you.
Thank you.